Dr. David Kummerfeld. I'm a shoulder and elbow surgeon at Azalea Orthopedics. One of the things we commonly encounter and get questions about are rotator cuff tears. What are they and who's at risk? So to make things simple, the rotator cuff is a series of 4 muscles that surrounds the shoulder that attaches from the shoulder blade to the ball of the ball and socket joint. So the front rotator cuff is the subscapularis, and it attaches to the front part of the shoulder. The supraspinatus sits on the top of the shoulder and attaches to the top bone. And then there are 2 more muscles on the back, the infraspinatus and the teres minor, that attach to the back. The rotator cuff is called rotator because it rotates in, it rotates up, and it rotates back. So that's what the rotator cuff is. There's a lot of different reasons why the rotator cuff can be damaged. Most commonly, it's degenerative changes that occur in the shoulder. And so as we age, we're at greater risk of having tears of the rotator cuff. The most common place to tear is the top rotator cuff, the supraspinatus. As we age, up to about 50% of people will have asymptomatic rotator cuff tears when they get into their 80s. And starting in the 60s, it's not uncommon for about 1/4 of the population to have tears of the rotator cuff. As a result, they can occur because of trauma. They can occur degeneratively just by nature of living. So it depends on how they occur as to how you address them initially. If you are a 50-year-old person with a completely normal shoulder prior to a fall and a dislocation, we treat that differently than we treat a 75-year-old person that comes in saying, oh, I have pain in my shoulder and it doesn't lift quite as well as it did 25 years ago. So let's take, for example, the person that comes in with chronic pain who says, over the course of time, my shoulder's gotten more painful and it doesn't give me as much lifting power as it did previously. So in that setting, I would get x-rays of someone as an initial evaluation and perform a good physical examination. That's going to be able to give me at least grossly which tendons are torn, if any are torn, and evaluate what our next steps should be. Most commonly in the setting of chronic rotator cuff tears, we'll elect for conservative treatment first, which entails non-steroidal anti-inflammatories, sometimes injections, although I tilt away from those personally, as well as directed physical therapy to strengthen the remaining rotator cuff tendons and the deltoid muscle, which is the big motor moving the shoulder. In the setting that someone does not progress in that circumstance with conservative management, an arthroscopic rotator cuff repair is very reasonable. On the flip side of that is someone who comes in that had a fall, had a shoulder dislocation or some big trauma to the shoulder that's not able to lift their shoulder. In that circumstance, I'm much more aggressive about evaluating them with physical exam and then subsequently an MRI and moving on to a planned surgical plan. And so what does surgery look like? A majority of these surgeries can be done arthroscopically, which is a big change from what occurred 20 to 25 years ago. Our arthroscopic skills have improved, our instrumentation has improved, and it's become standard of care to leave the deltoid intact and to be able to address these through small poke holes in the shoulder. And so these are typically day surgeries where we go in, we clean up the rotator cuff, get the mobility of that tendon. So as an example, we see if this tendon right here is torn off, typically it's sitting back in the joint. We'll grasp onto that tendon and make sure it can have good excursion over to the shoulder. We'll put in anchors up along the shoulder joint, and if we have good excursion, we'll do what's called a double row repair, meaning we have anchors that go close to the joint and anchors that go further out to the joint, so you compress that tendon against the bone. In the setting where we don't have as good of excursion, sometimes we're left with what they typically did several years ago, which is a single row repair, which still has good results and done arthroscopically or open. One circumstance for me where I do tend to go for an open procedure is if we have a tear of the front rotator cuff tendon. And typically that's going to happen more commonly in the setting of a shoulder dislocation, to where that entire tendon tears off, and personally I can access that much better in a open means. So like I said, that's done as a day surgery, come in the morning, leave that same evening, and then the hard part begins. Just because it's small little poke holes around the shoulder doesn't mean it's not painful. It is a painful surgery, one of the more painful ones that we do. And when you realize how much the shoulder actually does, you realize what you're losing throughout that time. So the initial 6 weeks or so, 5 to 6 weeks after surgery, is mainly trying to just get the shoulder to calm down and providing pain control. At that point, we start therapy, which is aimed at range of motion of the shoulder. And people vary with regards to their protocol post-operatively. Personally, I like to take things slowly so that I ensure that we have the best chance at healing. And then about 3.5 to 4 months down the line, we start specifically strengthening the muscle that we repaired. Biggest caveat that I can tell the patients regarding a rotator cuff repair, or the biggest thing that they can do to affect how they heal, is tobacco use. If you are a tobacco user or use any form of nicotine, that is, in my hands, the biggest variable with regards to healing a rotator cuff, because it relies on blood flow to heal appropriately. And so that's a big issue. So typically it takes about 4 to 5 months to really get a lot of the range of motion and a lot of the strength back. It's never as good as God intended it to be. We can get very good function, very good range of motion, but anyone who's torn a rotator cuff is always at a higher risk of a re-tear than someone with a completely normal rotator cuff. So being thoughtful about activities that you do, being thoughtful with continuing range of motion and strengthening exercises even after you're out of that initial 6-month period is something that I recommend to every patient. Now, there are those rotator cuff tears that are not amenable to repair, and in that setting we have various options as well, such as debridement surgeries, meaning we go in and take away some of the bad things that are causing pain, like the AC joint and the biceps tendon. We also have other options, such as tendon transfers, that can be done under arthroscopic assistance for people that have very large rotator cuff tears that are not amenable to being able to pull back over and plug back in where they're supposed to be. So in the setting that someone has normal cartilage in the shoulder, but just a very large rotator cuff tear, those are potentially an option. And in the setting of people that have very large rotator cuff tears that do have arthritis, or in the setting of someone who has a very large front rotator cuff tear as well as irreparable top and back rotator cuff, we start to talk about shoulder replacement as an option for that, which is called a reverse shoulder replacement. Those are things that have evolved over the last last decade and a half to become much more commonplace as a treatment for these issues. Those are the basics of rotator cuff tears and how we address them. I hope that's been helpful for you.